Good morning, everyone, and welcome to our second annual Pediatric Global Health Grand Rounds. It is with great pleasure that I introduce you to Dr. Nada Fadul, our speaker today. Dr. Fadul is a professor of medicine. She's an assistant dean of inclusive education at the College of Medicine, and she's also the medical director of the Specialty Care Center at the University of Nebraska Medical Center. She serves as the chair of the awards committee and a board of director of the HIV Medical Association. She's active in global health and runs the UNMC Sudan ECHO Global Hub, a telementorship platform which disseminates knowledge to healthcare professionals in underserved regions. She is the founder of the Sustainable Development Response Organization, otherwise known as SUDRO, and the Sudan ECHO Center of Excellence. Dr. Fadul's research focuses on implementation science and health services research on HIV health disparities. She has published in peer-reviewed journals, presented her research at national and international conferences, and mentored several students and trainees. Dr. Fadul's local and global work emphasizes on community engagement, cultural sensitivity, and gender and health equity. She's active in advocacy for patients with HIV and humanitarian issues facing Sudan. Personally, she enjoys writing, poetry, reading, and traveling with her family. Dr. Fadul, welcome.
Thank you so much, everyone. It's really my pleasure and honor to be here today. This feels like home in a way because I am from here, and it gave me an opportunity to connect with pediatrics, so I'm really glad to be here today. So this is a little different than the usual talks I give because this is really focused on the work that I'm doing towards helping Sudan, with the humanitarian crisis in Sudan. And it's not really the traditional academic work in a sense because it started more like service work and then eventually turned into academic work. And this is kind of a message to you if thinking about serving the community, but also implementing it with a purpose and implementing it in a way that will help these communities because you can produce information that will be replicable in the future. So I struggled with the title a little bit. I was going back between empowering and not some other words. I felt like empowering is a word of hierarchy, like we're coming here to empower these communities. I used the word help earlier, but also that's a hierarchical word. But I feel like right now Sudan is in a position where we need the help, we need the empowerment, we need every support that we can get. So this is a time when we need to kind of just balance what's happening there and say these communities are in a position where they do need that empowerment because the global north sometimes tend to decide what needs to be empowered and what doesn't need to be empowered. And you should leave it to that community to decide. And the communities there are telling us right now, we need the help, we need the empowerment. So we should respect that as well. So I'll go ahead and get started. These are my disclosures. I get research funding from VIV, and I'm on the Health Equity Advisory Board. So the objectives of this are to examine global inequities impacting Sudan specifically and the potential contributing factors, and explore the current situation and local and international response to the Sudan's conflict. And then at the end, we're going to propose a framework that engages communities in humanitarian response, so where communities can actually take action and take ownership of what's happening with them. So this is a little background about me. So I'm from Sudan, and Sudan is in Northeast Africa. It borders the Red Sea, and from the north it borders Egypt. From the west it borders Chad, and now there is Sudan and South Sudan. In the past it was just one country, and in 2011 it got divided into two countries. I'm from Medani, which is kind of in the almost center of Sudan. I call it the heart of Sudan because it's left center. And I grew up there all my life, but I'm from the Nubian region of northern Sudan that borders Egypt. And this is a picture of me when I went there in 2019, and I finally got a chance to actually visit my origins and identify my heritage, and it was just such a proud moment for me. This is one of the pyramids in northern Sudan, and when I say that to people, they're like, oh, there are pyramids in Sudan. And yes, there are pyramids. There are about 70 pyramids in that region. And this is a pyramid of a queen, an ancient queen. And if you are familiar with Bible, there is Candace in the Bible. And Candace is basically Kandaka in Nubian. And Kandaka means the fighter queen. So this queen actually fought the Romans and went up all the border to the Egypt and ruled that whole region. And she led these armies. And that kind of is a representation of Sudanese women. We're fighters. You know, we are not very easy to kind of put down. And that's what's happening right now in Sudan. And I'll share a little bit about that. So in terms of the population of Sudan, so the word Sudan itself actually derives from the Arabic word Bilad al-Sudan, which means the land of the blacks. And if you're familiar with Northern Africa, it's primarily whitish population. Sudan is kind of the link between Northern and Sub-Saharan Africa. And it has a mix of population, like it has all kind of shades and colors of people. The population is about 47 million. It gained its independence in 1956, but since then it never had a stable government. It had 3 military coups, and al-Bashir government, which was Islamist fundamentalist government, lasted for 30 years and finally ended in 2019 with a big, great revolution. And that revolution led into a transitional government that was civilian and military shared. And there was a coup in 2021, unfortunately, that ended that transitional government. And that resulted in a war that started in 2023. And this is really kind of important to what we're going to talk about earlier. So I want to give you some context of why we're talking about this. So this is a shade of people in Sudan. Sudan is really a poor country, unfortunately. It has so many resources. We have the Nile running across the country from south to north. We have very rich agricultural land. We have lots of minerals. We have gold. We have uranium. But all of those resources are kind of taken out of the country in a raw fashion, so the country is really not benefiting from them. And this is as a result of a colonization that has lasted for centuries in Sudan, that the country was never really able to stand on its feet because of that colonization that divided the country so much. So the healthcare status in Sudan is very devastating, unfortunately, because of that dictatorship. That resulted in a lot of the GDP being spent on security because the government wanted to stay in power, and the way they could do that by oppressing the people. And the way they can oppress the people is to emphasize expenditure on security forces, military, etc. So only 2 to 8% of the GDP, the gross domestic product, was spent on healthcare. And if you look at the division of that, that was kind of varied across the years, but that went down to about 3% in 2020. And this coincided, obviously, with the COVID pandemic. And if you look at the division between private and governmental, you can see that most of that expenditure is actually happening in the private sector. And if you're talking about a poor country where people are not able to afford a lot of the necessities, for them to be able to access private healthcare is a big barrier to accessing healthcare. So this is where Sudan falls in terms of the global healthcare access and quality index, which is a crude measure of healthcare access and quality across the globe. It's not the best measure because it derives from data that's sometimes not really complete. But even based on that, you can see that Sudan falls towards the lower end of the spectrum. It's not the total low, but it's definitely in the lower end. Now, this was not updated since 2015, so it's very old measure, but it's about 45 out of like 100 or so. So if you think about these global health inequities and why do they happen, they're not really that much different than what we see here in the United States in terms of health equities. They're driven by a range of factors, so socioeconomic and sociopolitical factors are a big part of that. Poverty, income inequality, levels of education, employment, all of those play a big role into healthcare services and access and equality. So you can see that countries that have better measures in those things, then they have a tendency to be on the better end of the spectrum. And countries that are not yet able to overcome that impact of colonization, whether it's in Africa or South America, they're still struggling with their healthcare impact and access. Now, marginalized communities, rural communities across the globe tend to suffer from healthcare inequalities. And many of these countries also have gender inequalities as well. Not necessarily because in Islamic countries, women are oppressed, because I already told you how women in Sudan function and they're so independent, but it's just the system is not based in a way that it empowers women to take ownership of their own health, and women tend to not rise to places of leadership where they can actually make decisions to help other women. And, we're seeing that in different places of the globe, including this country, unfortunately. There is also the impact of climate change. So that is impacting these rural communities across the globe really harshly. So right now in Sudan, in addition to the war, there was a major flood that impacted many parts of the country, and that led to outbreaks of malaria, dengue fever, cholera. And you're dealing with communities that are displaced from the war, and now on top of that, they have to deal with cholera and malaria. And all of this actually came to surface when the pandemic hit. So this was happening. We knew it was happening, but it got our attention when the pandemic hit, because the pandemic kind of equalized the world in a way that we needed to control things in other places in order to control the pandemic here. So if you can't just say, we're just going to worry about our borders and leave people in other countries to deal with this on their own, because it's eventually going to travel and come here. The world is much smaller than it used to be now. So as a result of many of these inequities and the political situation in Sudan, there was a genocide that happened in Darfur back in 2003 to 2013, and this resulted in major destruction of the infrastructure, the little infrastructure that was present at the time, the healthcare specifically infrastructure that was damaged, in addition to the atrocities that were committed in that region, anything from massive killing to rape, the burning of villages, etc. And Darfur is the western border of Sudan, and that was driven by basically an ethnic cleansing process, because the Arab majority of Sudan decided that the African minority of Sudan should exit this land so we can take care of it and we can take advantage of it. And the land where this minority was residing is very rich in gold, very rich in minerals. So the process that they did that is actually, unfortunately, committing a genocide and displacing them from the land. And they used lots of excuses why they needed to do this. They used Islam, they used all kinds of excuses, which completely did not align with what the goals of Islam is. So all of this ended in 2019 with a massive revolution. The revolution was led mainly by women and youth. Like the average, the median age in Sudan actually right now is 19. 60% of the population are less than 35. So that population was fed up. And now with globalization, access to internet, access to social media, people were like, okay, we need to live like the rest of the globe. We want to have our independence and freedom. And they finally went through this big revolution process that resulted in toppling the dictatorship of the Islamist fundamentalist government. This is me here in D.C. in front of the Capitol, chanting and shouting. This was happening during the same time that the revolution was happening in Sudan in June 2019, and we were advocating for the U.S. government to actually pay attention to what's happening in Sudan and assist the Sudanese people. We organized 2 marches in February and June of 2019, and they were attended by thousands of Sudanese. And I felt that, I have a privilege living in the United States, having access to my representative, having access to media, having access to resources, that I need to use that voice. I can't just sit at home and, I didn't expect somebody to take a nice photo of this, but I needed to basically represent and bring those voices that were oppressed across 1,000 miles from here. So Sudanese went through all that. They finally have now a semi-civilian government. They were celebrating that. I went back to Sudan in 2019, and I wrote a blog. The name of the blog was "Freedom Was in the Air." And that's really how truly I felt. I felt like there is freedom in the air. People were just celebrating across the country. And then COVID happened, right? So COVID just exposed all of those things that has been destroyed in the past 30 years through the dictatorship, the fact that we did not have any public health infrastructure, that hospitals were not equipped to deal with all this massive entrance of patients. Isolation centers where patients with COVID were sent were completely overwhelmed, and patients were going there even though they had mild symptoms because they were frightened. They were hearing about COVID and how it kills people. So the minute you start coughing, you go to the isolation center asking for COVID tests, and testing was not available. On the other hand, if you go to the markets and if you go to mosques and if you go to homes, there was really poor adherence to social distancing, to masking, and all of those things. So COVID was rapidly spreading in the community, but the isolation centers could not cope with that. But as we all knew at the time, 85% of patients with COVID-19 did not need to be in a hospital. They did not need to be in an isolation center. They can be managed safely at home. But there was just not enough resources to manage these people at home. So here, remotely, being in the U.S., being an infectious disease physician, I was getting calls from family members, from friends, telling me about their symptoms, telling me what I need to do. And I say, don't go home, don't go to the hospital, stay home, and I'll call you tomorrow. If you're feeling fine, we'll just do this remotely. I'll tell you what to do, take vitamin C, all of this stuff that we knew that's probably just placebo, but that made them feel better. And just stay home and I'll call you tomorrow. So WhatsApp made it very easy to communicate back and forth with family members and friends back home. And then before I knew it, people were sending their friends of friends and family members of family members to me. And I was getting all of these massive calls. So at some point I was managing 10 patients remotely from here. I'm like, I cannot do this. I have my own on-call schedules here. I have my own responsibility. It was just really too taxing. So we reached out to some friends of us back home and said, hey, would you be willing to be trained by some of us here to be able to do this? They're like, oh, yeah, please help me do this. And before we knew it, we got this kind of excitement that people wanted to be trained to take care of COVID-19. So this is my friend, Dr. Reem Ahmed. She's a faculty at Emory. She's a hospitalist there, so she was also very familiar with management of COVID. So we collaborated in doing this and putting this together. We were part of a coalition called the Sudanese Coalition Against COVID-19, and there was a lot of diaspora engagement in trying to help the country overcome this. So we founded this project. It's called the Community Medical Response Team. Initially, we started training specialists, internal medicine specialists, on how to manage COVID-19. And then before we knew it, there was a lot of interest from house officers, which is equivalent to residents here. And there were students who graduated from medical school, but they were not yet placed into residency because there was a delay. So they came and said, hey, we're graduating. We know how to manage things, so can you help us do this as well? So we reached out to the government, to the Ministry of Health, and said, we can do this. Do you want us to help? And we put together this community medical response team. We put together protocols, et cetera. And the Bill and Melinda Gates Foundation had this protocol for engagement of communities in crisis response. And these are the 6 steps listed here. So the first step that is extremely important is to assess the need and nature of crisis response. You need to understand the context of where you're going to be working, and you can't really do that completely remotely. Even though I'm Sudanese, I needed people in the country who understand the concept to train me and teach me about what's happening. So we needed this to be a bidirectional exchange of knowledge. Then you organize your team, you train the team members, you then implement your crisis response, and you make sure you have some quality metrics that you're following, and that then translates to community intervention and training of key populations. And you have to build that trust and acceptance with the community. So this is a very long process. If it's done correctly, then it leads to sustainability, and if it's not, then it ends up dying usually within a few months to a year. We put together this checklist based on CDC community worker checklist. I'm not going to go into details, but it goes from plan, implement, evaluate, and sustain, and it's a cycle. After you sustain, you still need to continue planning for what's the next thing that we're going to work on and continue that process of evaluation and sustainment. This is really important because, again, unless you do this systematically in a thoughtful way, it ends up being, unfortunately, a bad use of resources. The most important thing that we did is we founded a local team, and I hope some of them are online right now because this team was critical to the success of this. And as you can see, there was a predominance of women, which was intentional because I'm a big advocate for gender equity, and sometimes that equity needs to go to the left side in order to balance because men by nature in Sudan have dominance of a lot of things. Mohammed Abdullah, however, has been a champion of a lot of things, so we couldn't really do this work without his involvement. So right now he's acting as the vice president of the organization. Lena, at the time, was the coordinator and the director of the team in Sudan, and she was just a fresh graduate from Ahfad. Some of these actually are students until this day. So Saida is a student. Mohammed Abdullah just graduated from medical school. So young, youthful, very energetic people who stepped up and said, hey, we want to do this. And these people went and sat down with the Minister of Health, sat down with deans of their schools to get this work done. So they were amazingly engage this whole process. We use Project ECHO, which stands for Extension of Community Health Care Outcomes. And what I love about ECHO, there's two mottos that they use. One of them is democratizing knowledge. I love that term. And then moving knowledge, not people. So the idea here is that you don't really need somebody to travel to go to a tertiary care center in order for them to get the health care that they need. You can move the knowledge downstream to the primary care centers, to the community, in order for that community to be able to benefit from tertiary care level of knowledge. And that's exactly what Sudan needed. People did not need to travel all the way to Khartoum or big cities in order to access COVID-19 treatment. They could get that treatment locally if we train that community. So usually we have a specialist team, which is, in this case, was Rima and myself and some other consultants from Sudan, the participants, which was our CMRT, and then that benefit will then eventually go to the community. But the important part of this is that it's all teach, all learn, right? So it's not only that you're learning or you're disseminating the knowledge, but you're also learning. You're learning all the way from the community. And this is done through case-based discussion. So when the students and the volunteers go and engage with their community, they come back with cases from that community. And they say, we have faced this barrier. The community has told us this, or this was a successful experience. I did this, and I talked to this group of people, and they gave me this idea, and we need to think about implementing that. A good example of this is one of the sessions we were talking about COVID vaccine misperceptions and misconceptions. And believe it or not, people across the globe still believe that Bill Gates had a chip, that he wanted to create an army and so forth, and that was actually a belief in Sudan as well. So we had to try to dispel those rumors, and the way we could do that is by spending a lot of time training the volunteers on how to actually have that communication, because you can go to people and say, oh, this is not true, but is that really going to work? The way to do this is to listen to their concerns. Those concerns are stemming from a lot of issues, a lot of inequities that happen to them, a lot of atrocities, a lot of mistrust in the colonization system that treated them really poorly. So they had the right to believe that the global north is now intending to enslave them in some way, because that's their experience with the global north. So we had to listen to that and try to slowly kind of dispel that rumor, but not immediately in a confrontational way say this is not true. And that's what we trained the volunteers on. So they came back and said, hey, we went and talked to this community, and they said, we know this is not true, and we want to get vaccinated, but in order for us to get vaccinated, we have to travel 20 miles to get to the nearest vaccine clinic. Can you bring the vaccine clinics here to us? And we're like, oh, that's, well, maybe let's think about that. Why is that not possible? So we sat through that, thought about a plan, and we went to the Ministry of Health and said, hey, can we have a mobile clinic? At the same time, we were actually having mobile clinics here in North Omaha. Dr. Delaire and others were involved in this effort to bring vaccines to North Omaha. So it was like, we did it here. There's no reason we can't do it there. So we spoke about this to the Ministry of Health and said, we tried that. It wasn't really successful, but if you guys want to try it, we'll try it with you. So we had a vaccine clinic organized in a remote suburb of Khartoum, and the volunteers took 500 vaccines in collaboration with some staff of the Ministry of Health on a Saturday. The Friday before, they went to the Friday prayer and announced the vaccine clinic. They spoke to people. They addressed their concern. And next day at 9 a.m., there was a line waiting for vaccination. And they ended up vaccinating 2,000 people that day. And that was like a big shock to all of us. We did not expect it to be this successful. And that actually started a series of vaccination campaigns and vaccination clinics in 7 states around the country, led by these volunteers themselves, actually. So you can learn from the community if you engage with them and if you listen to them, actually. We had sessions, anything from mental health hygiene, principles of infection control, leadership clinics, and at some point there was an outbreak of viral hemorrhagic fever, so then we had sessions around that. So this is our first year ECHO outcomes. This is a lecture hall at University of Dongola where people were attending in person, and then there was a screen where people were engaging remotely. It was like a work of labor, of love to try to arrange something like this because it was very difficult. Internet access was a problem, et cetera, et cetera. A lot of things we take for granted here were not as accessible there. So by the end of the year, we had 35 sessions. 12 of them were actually about leadership and communication and principles of community engagement. And there were 24 subject matter experts from around the globe. So these are diaspora, most of them Sudanese diaspora who wanted to engage back with their community. And we had this done in 6 states across the country. So when we looked at cumulative knowledge before and after session, so people were rating their knowledge before and after session, and they did say that after the session they were more knowledgeable, they felt more confident in their knowledge, so it went down from like 13% very knowledgeable to 44% very knowledgeable, and this is a cumulative response for all of the session. Also, when we asked them, is this relevant to your current work? There was a lot of agreement to that because we were discussing cases that were actually happening in the community at the same time. And would you recommend this session to your other colleagues? A lot of them said, definitely, yes, I would recommend that. And would you apply what you learned in your daily work? Again, a lot of them said they would do this. Now, what was really important, though, that this was translating into community impact. So we managed 77 patients in home isolation. We had a lot of vaccine awareness campaigns across the country in 7 states, and there were 65 mobile vaccine clinics, resulting in 25,000 doses of COVID vaccine being delivered by students, residents, trainees, anyway from a young student in second year of medical school to a consultant working together in a campaign to deliver these vaccinations. And this was a really big success. It empowered these volunteers to think that we can do more, we can do something to help these communities. We need to sustain this effort. And the evaluation part of this was really important because we were tracking these metrics regularly and celebrating those small wins and successes on a regular basis. And that kept people motivated to do this, even though they were not getting paid for this. This was all volunteer labor. These are some of the photos of vaccination campaigns. You can see, they were sitting under a tree registering people. This is a student actually who went down in the desert and found this shepherd and started talking to him about COVID vaccination, telling him we have a vaccine clinic tomorrow that you need to. So the way he's sitting down, the posture, the body language, is basically that humility that makes you connect with people at a human level that really made a difference. This is really important when you're doing global health engagement, that you need to understand the culture and the practices of that community before you even get there, before you land in the airport. This doesn't work for all communities across the globe, right? So, Boeing is not really like a language in Africa. You can't really do that because people will be like, what's wrong with you? So you have to understand how this community communicates, how they talk. Not necessarily the language, but even the body language and the gestures so they can communicate. Some of them had to go to people's home because some people were not able to walk to vaccination clinics, so some students ended up going up to people's home to vaccinate them. There was a lot of media attention to this effort, so we had few journals and others that were publishing this work because it was really innovative in a way that you get students, community engaged, and then they end up doing something really meaningful and useful to their community. And it was done in Sudan. There's no reason it cannot be done here. So we're going to watch a short video. It's a 7-minute video, but we're just going to choose a clip of it to hear from the students in their own voice.
The knowledge that we gained has helped us engage our communities better and better tackle problems and concerns in our communities. Also has helped us see them in different angles and perspectives. This has especially been helpful in dealing with a very, you can say unpopular disease, which is COVID-19, of course. Using the skills that we learned, we were able to convince more people to listen to us when we talked to them about the importance of the preventive measures against COVID-19. That added to the vaccination campaigns that the different teams carried out all over Sudan.
We learned so much from the ECHO program. We had the opportunity to meet a lot of subject matter experts and improve our knowledge, our communication skills. CMRT gave us the opportunity to travel, to learn, to be engaged in our community, and to give something to our students.
When it comes to the ECHO, I think I might wait impatiently for the ECHO sessions to come and to meet the subject matter experts, to learn from them and so. And of course, in the ECHO, we find the solutions and the answers for our questions regarding the problems we face in our community, in our local level. So to summarize, I think I would say ECHO has gained us the skills and the knowledge to handle our problems in our community during the COVID-19 pandemic.
What is your most favorite CMRT memory?
Well, my favorite memory would be a little difficult to mention because my favorite memory continues to be renewed in the CMRT. But I can tell you about my most recent one. It happened when we were working on a poster for an introductory session to the CMRT. And we asked about the number of people who were vaccinated through the vaccination campaigns that I mentioned to add that information to the poster. And the number was just astonishing. It was 20,000 people who were vaccinated against COVID, which was as I said, unpopular worldwide, but especially in Sudan, because people wouldn't want to listen to anything that has to do with COVID-19 in Sudan. When people started talking about it, people just walk away. So 20,000 people were vaccinated by the collaborative efforts of all the volunteers and our astounding supervisors. It was truly an amazing feat.
One of the best memories that I had in the CMRT is the vaccination convoy we heard in the northern states, in which we reached actually far places where there is no accessibility to the vaccine. We fought so much vaccination hesitancy, and we always recall what our mentors told us about if you vaccinated one, you actually saved one. And I remember by the end of the convoy, we actually vaccinated 1,250 persons, which was really amazing.
And finally, would you please describe CMRT in one word?
To describe the CMRT in one word, it would be treasure chest. I mean, I know that's not one word, but it's really difficult to describe the hordes of opportunities that CMRT creates and the amount of youth potential that it takes and directs towards bettering community health. It's just truly indescribable. Well, yeah, there you have it. Another word, indescribable.
I have been asked to describe the CMRT in one word. The first thing that came to my mind is family. I literally felt that I'm accepted in the CMRT. I found the support, the approach to my problems. Whenever I ask something, I find it there. I felt very welcome in the CMRT. So the most descriptive word that I would say is family.
I can summarize the CMRT in my heart as home, country. That's the CMRT for me.
So as I mentioned, these wins were really encouraging to people to go on and have other echoes. So this echo, actually, the CMRT echo, was held out of University of Nebraska Medical Center. We had an echo hub here, bringing subject matter experts from across the globe, but some of our faculty actually participated in those echoes, especially with vaccination, infection prevention and control, etc. The next echo that followed was community-oriented primary care. And this is a public health methodology that's used to deliver community health care in remote and underserved areas. And this was really targeted towards remote areas because there is no accessibility to primary health care in those regions. Preventive care is not really a philosophy there. You go to the doctor when you're sick, but you don't go when you're healthy. So this was intentional that we need to reach these places and implement some preventive care measures. And then after that, we had the leadership and peace building echo because there was a lot of turmoil happening in the country at the time. University of Jazeera also had their own rural primary care echo. Peace engineering, University of Sudan Technology and Sciences had a peace engineering waste management echo. And then the Federal Ministry of Health had their own patient safety and QI echo. Now, CMRT was the first echo in the country. Before that, there was no project echo, and these all followed after these amazing students started this type of work. Now, this led us to think broadly about how can we put this type of work into a bigger framework. So ECHO basically brings these subject matter experts engaging with learners in an ECHO hub, but that could be translated into community projects that then help empower those communities to go on. So with the engineering ECHO, the peace building ECHO, all of those happening at the same time, we put this into a framework of sustainable development goals. And if you're not familiar with this, the UN actually established SDGs to improve health, wellness, climate change, there's 17 SDG measures that they're following, and the plan is by 2030, the globe would be a much better place. And now it's 2024, so I'm not sure if we're going to achieve those sustainable development goals, but around the globe, these are the measures that are used traditionally to measure development. So these are the things we focused on, and we had ECHOs working at the same time, ECHO hubs working at the same time. So we then thought about forming this organization, SUDRO, Sustainable Development Response Organization, and then the ECHO Center of Excellence. The idea was to exchange knowledge between the projects and the ECHO in a way that actually translates into these community projects. Now, the important thing about this, you really have to, again, I have to emphasize that you have to learn from the community and you have to continue to engage with the community, but it doesn't have to be in person. I did not travel to Sudan since 2019. So all of this work that we have done in Sudan has been remotely. I have not met many of these volunteers yet in person. But, you know, we have such an amazing bond and relationship. I'm able to mentor them on a regular basis remotely via WhatsApp sometimes, via Telegram, because sometimes we cannot get on a video call. Sometimes we get on Google Meet. you can find ways to be able to do this if you have the will and you have the determination. We need to stop thinking about global health being a tourism type of experience where you go into places and you spend time and you just pack up and leave. Global health really needs to be that continuous engagement in order for it to be successful. Unfortunately, we finished 2022. We had really big dreams and hopes for 2023, and a war erupted in the beginning of 2023 that just put everything into halt. The war now has been going on for 18 months. It resulted in 24.8, almost half of Sudan population needing humanitarian assistance. 14 million people have been reached out of that 24 million people. There is about 9 million people displaced inside Sudan, and there are 2 million people who have actually fled the country because of the war. And they fled the country in all directions, as you can see here. The red dots are places where there is active conflict happening, and this map is actually very recent. It's from last week. So until this day, there is active conflict in pretty much half of Sudan regions. The only safe regions are the north and the eastern of Sudan, and people don't know how long that's going to last, unfortunately. So when the war erupted, April 15th, 2023, everyone was just kind of shattered, in shock. What is going to happen to me? What's going to happen to my family? So we immediately stopped the work, told people to focus on your safety and your family. But April 23rd, people came and said, we need to do something. Nobody's able to get to hospitals. Hospitals are being targeted. We need to do something for our community. And we said, okay, let's just focus on something we could do safely, which is training. Let's try to train people who are already working in hospitals on how to take care of emergency care, because emergency medicine is not a subspecialty in Sudan. And that's what people said. We need that training because we don't have emergency medicine as a subspecialty. So we worked with Project ECHO. They had just concluded a training program in Ukraine a year before. So we said, can we use your material? Can we use the stuff that you had done to train people in conflict, combat zones on how to manage minor traumas at least? So we collaborated with them. We have a Telegram group. So Telegram is a social media app, but you can actually have video conferencing and you have slide share and everything you could do on Zoom, but it doesn't use a lot of internet bandwidth. So even if you're in internet resource setting, you can actually use that. It had 5,000 people. Once we announced the program, it grew up immediately. 14,000 people joined the Telegram group. We delivered 43 sessions. The WHO local office and the regional office joined us because they had a lot of sessions that they wanted to deliver about case management, infection prevention, et cetera. And we delivered those sessions. They were attended by 2,700 attendees within about 6 months or so. And that was another success example that you can be agile. You don't have to stick to your specific aims, those that tell you this is how you do things. You sometimes need to switch. You need to pivot to meet what the community needs at that point. This was never in our intention to do emergency training, but when the calling came, we had to do that. Again, this was also translated into community. People were displaced across the country. Some people packed up whatever they can and left their town without their medications, without any health supplies, without, my parents actually have high blood pressure and diabetes, and they had to leave. And my dad, after he got to a safe city, he realized he didn't get his blood pressure medicine with him. So we had to scramble last minute, find a place where he can get his blood pressure medicine. We found one of them, we couldn't find the other, and thousands of people were dealing with this on a daily basis. And there were displacement camps. Those that were mostly in schools, in dorms, et cetera, that were turned into displacement camps. But there was ability to actually go to displacement camps and hold mobile clinics there. And the volunteers came up with this idea, why can't we have mobile clinics in these displacement camps? I'm like, great, let's talk to the Ministry of Health, let's talk to the WHO, let's talk to these organizations so we can put together these mobile clinics. And they're very low cost. I mean, all you need is a bag where you put your supplies in. You need a laboratory technician who knows how to transport lab material from one place to another, because all we do is point-of-care types of labs. And you need medications. So as long as you have a collaboration with pharmaceutical source, which in this case, most of the time it's WHO or Ministry of Health, you can get those supplies. So we held mobile clinics. These are a little odd numbers. I just looked at the updated numbers yesterday. We have reached 24,000 patients with these mobile clinics. And again, the clinic could be in a very resource place. This is I think it might have been a classroom in one of the schools at some point. So they organized a clinic there where people who are displaced could come and get their chronic disease medications. But they were also treating some acute medications, UTIs, et cetera, whatever the population needs. And look at this. This is a lab in a tent. You can put this anywhere. This is a pharmacy in a tent as well. And this is registration outside under the tree. So you can, again, be agile and meet the people where they need you to meet them and meet them where they're at. They also had awareness sessions, sexual reproductive health training for women, all kinds of types of awareness sessions that they needed. There was a cholera response program that we participated in collaboration with the WHO, where we held what they call oral rehydration centers for kids with cholera, because there was a big outbreak at the time of that. There were a lot of challenges. This was not easy. There were issues of safety instability while moving from one place to another, because you could be stopped by the militia at any point and be asked, what are you doing? And why are you doing this? And whom are you doing it for? So they had to also focus on their safety and do this in places that are very safe. There were displacement of volunteers. We had volunteers in one state, and before we know it, that state is empty because of the attacks that happened. Lack of internet connectivity, lack of supplies and funds, and there is a lot of bureaucracy from funders. To deal with the WHO, you have to be very patient to be able to get supplies and funding, and that sometimes can hinder the response, but you have to also be persistent. This is really a big call now for what we're advocating for, which is localization of humanitarian response. You give the response and the aid to the people, they're able to do it. They're able to deliver it. They're able to funnel it in the places that are needed, much better than international agencies coming to the country with no experience, no awareness of what's happening in that country, and trying to dictate how the response should be in that country. So this is a spectrum now that has been developed by an organization in the UK, From Poverty to Power, and it talks about how do you localize response and what that spectrum is. So the spectrum goes from no localization, where international nonprofit organizations come in with their funding, with their supplies, and they make decisions about what needs to happen, how it needs to happen. They bring all their staff with them, and they go there to manage the response in their own way. There are places where there is limited localization. You do engage with the community in the beginning. You ask them what they need, how they need it done, and then you give them some of the supplies, but you also make decisions. You're still holding the decisions to yourself. There is partial localization, where you engage with these communities on a regular basis. You engage with them in the beginning, you go back and get feedback, but you're still holding the decision-making power to yourself as an international NGO. And then you go all the way to locally led. Locally led is where you let the local people lead and manage decision-making about how this response should be done, because they're capable of. And we've seen that with the CMRT case. You give them supplies, you give them funding, you give them training, they're able to manage this response. They know exactly which isolation center needs the resources. They know exactly which displacement camp has most people in need. They know exactly where the cholera response needs to be happening. You let them lead this, and you stay in a mentorship and a guidance place, not in a supervision and decision-making place. And if you do that, then you're able to be much more agile, be much more efficient in the international response. This is not happening, unfortunately, and there are a lot of reasons why it's not happening. And let me give you an example of what's happening right now in global humanitarian response. So the U.S. has been traditionally the biggest donor to humanitarian response. So in 2016, there was a need of humanitarian response across the globe. The U.S. had put $12 billion into that response out of $16 billion. The $16 billion was gathered from EU, et cetera, in addition to the U.S. Out of that $16 billion, 1.3% went to local NGOs. 1.3% out of $16 billion. Where did the rest of the money go? It went to medium NGOs or medium actors, such as UN organizations, international NGOs, implementers, and a lot of that money stayed actually here. It never left the country. It was used for administrative work, it was used for employment, it was used for transportation, it was used for travel. It was used for so many purposes, but not for the people who are suffering from malnutrition, the people who are suffering from communicable diseases back there. And this is an example of such a bad way of managing response, because we feel like we're the ones who know this. We need to do this in our own way. And what happens is that we employ thousands of people who don't need to be employed, because we could have employed them back there, right? At least give people there a job when they're battling humanitarian response. Now, why is this not happening? Because of issues that we put in our mind that those people don't know how to do things. We know better. There is corruption happening there. We are not as corrupt. Bureaucracy that we put in the system that hinder those local organizations from being able to access the response. So, for example, to get funding from USAID, you have to be registered in the U.S. federal system, which is called SAMS.gov. Now, UNMC is registered in that system. Children is registered in that system. And the registration process needs an employee, like, to actually be devoted to this registration and be on top of the registration and the federal requirements of this system. If you ask a youth group like the CMRT to be registered in the SAMHSA.gov system in order to get aid from USAID, the first response would be like, I don't even have internet connection to make a phone call via WhatsApp, let alone stay online for 2 hours to be able to fill a registration home. So we put all of these requirements that make it inaccessible for these people to be able to get the humanitarian response. The other thing that I need to emphasize is that we think of these people as people in need. We don't think of them as assets. And we really need to move from the terminology from need to asset. We need to think about them as the asset to this humanitarian response. They have a lot of agility. They have a lot of creativity. They have a lot of potential. But we always put it in our mind that they need help. They need support. And what does that make us? It makes us a savior, right? It makes us the one who have this big, superhero cap that we're coming here to rescue you from whatever you're going through. I'm not going to go into this in details, but I want to share this because I'm really proud of one of our SERF students who actually worked with me during the summer, did an extensive literature search, and we came together with this framework that outlines what's happening in Sudan right now. And we took that and flipped it into potential for rebuilding of Sudan. How do we use these lessons from the humanitarian response and the example of community engagement and how successful that community engagement was, and use that to actually illustrate how this can be used for developing Sudan in the future. And this centers the community, whether it's local organization, whether it's diaspora like myself, whether it's healthcare workers there, whether it's youth volunteers working together to rebuild Sudan healthcare system. She used the flag colors of Sudan to illustrate this inverted pyramid, and the bottom of the pyramid is the Federal Ministry of Health. So putting power at the bottom of the pyramid and putting the local community on top, and this was very intentional. The local community can lead this rebuilding process and getting them involved in any shape or form, whether it's an advisory council, whether it's a tribal council, to help aid the government into letting them know, and international NGOs, into what we need happening to our country is really going to be the most impactful way to deal with this. So in summary, capacity building and bilateral knowledge exchange is really a key to community engagement in low middle income countries. Knowledge translation into community projects is feasible, is doable, but you need to involve the local community in doing that. And at the end, you center the community. They lead the interventions rather than you leading them remotely to tell them what needs to happen. And that will eventually lead to localization of humanitarian response. And we could use all those lessons in development, in political transition, in peace building, in a lot of other things. So this is really the take-home message, is that if you engage the community effectively, you'll be able to walk much faster than if you walk this walk without them beside you or following you behind you. So this is a photo of this team in the northern state after conducting one of the displacement camp clinics. And I love this quote from Desmond Tutu: do a little bit of good where you are. It's those little bits of good put together that overwhelm the world. So thank you very much for your time and for your attention, and I'm happy to take any questions.
Start us off, if you don't mind. Thank you, Dr. Fadul. That's just inspiring. And what I'm very curious about is you've given us sort of one iteration, I feel like, of your kind of PDSA cycle where you moved from COVID response to emergency care. How do you continue to iterate, and where do you see this work in Sudan heading next toward rebuilding and sustainment?
Yeah, that's a wonderful question, Carrie. And that's exactly how we kind of moved from one thing to another. So initially, the plan was to move from COVID response to primary care. And that's really where we're hoping to go next. There were so many primary care centers across the country that were not staffed. They had the equipment, they had the resources, they just lacked staff. And that happened because of the brain drain that's happening from Sudan right now. A lot of people are leaving the country, a lot of medical professionals. But we had the human resource. We just need to train them a little better to be able to staff these countries on weekends, on after hours, etc. So that was, we're hoping to go next. Now it flipped completely and went to the war response because of what's happening. But that's still the intention. When we go back into this respond and develop mode, hopefully, because I don't think we will be able to immediately jump into development with what's happening in the country right now. I think we're still going to need to be responding to little emergencies here and there, outbreaks of communicable diseases. But the idea is that while you're doing that response, you can also develop at the same time. And you can't just respond and pack up and leave. You need to leave that community with some resource in order for them to continue building on what you have just delivered to them. And that sounds a little too dreamy, honestly, sometimes, but it's doable. And we have seen it in some places where we brought youth groups from that community and said, there was a dengue outbreak here. We came and we helped with infection prevention. We went through houses and, told them how to empty pockets of water and how to, help drain water from places so mosquitoes are not breeding. So before we left that area, we brought youth from the community, and we sat down and we trained them on how to go around doing infection prevention for dengue fever. And when we went back a year later to do the same thing, the youth were already there and helping before we even landed, and they knew what to do. And I think this is an example of, training community with some of the techniques. They're not going to be able to do everything that you did, but at least leaving them with some lessons that they can then carry forward could be a way to help develop. But the biggest need of Sudan, if it ever recovers from this war into a development phase, is going to be the primary care system. Because right now, in the past, it used to be communicable diseases, malaria, et cetera. But right now, actually, one of the biggest causes of death in Sudan is cardiovascular disease. And just like the rest of the world, we're battling obesity, we're battling food insecurity, all kinds of things. And that going back to primary care and prevention is going to be really a big necessity. So I'm hoping we'll go back to that community-oriented primary care ECHO in the future and be able to implement that. The other thing that we're working on right now, and actually we're meeting with different organizations to put this together, it's the Health for Peace initiative. And the WHO, I think in 2022, released a Global Health for Peace initiative. And the idea there is that healthcare workers are actually trusted people in their community. And we function better in peaceful environment than we do in chaotic and conflict zones. So we're putting those two things together. If we can come in with a message of peace to that community, in addition to delivering healthcare, with that trust that the community has in us, they're trusting us with their lives, right? So they're coming there trusting with their lives. So if you can interact in a way that promotes peace in that encounter, in that setting, whether it's flyers on the wall, whether it's an awareness session that's being held in the next room, you can actually slowly promote peaceful, cohesive living in that community. And this is our next endeavor. Unfortunately, right now, peace is not a good word in Sudan. It's looked at as a bad word because the militia is committing a lot of atrocities, so the military's goal is to get rid of this militia. So the war needs to continue until that happens. But the country is really not in a place to have continuous war. Like, it's basically collapsing. So there is a lot of advocacy for peace, but you have to do it in a subtle way that's not really looking like you're supporting the militia continuing its operation in the country. So those nuances, and all of this was something that I needed to learn from the community, because when I talked, for example, to Muhammad Abdullah, I said, we need to implement this, we need this global health for peace initiative. He's like, oh, no, hold on. If I go and say peace, I'm going to be beat. They will kick me out of that displacement cabin. I'm like, what? He's like, yeah, this is what's happening in the country. And I'm like, okay, well, I was humbled in that moment, and let's just think about it in a different way. The potential for this to work is actually already there. So the northern team went to a camp that had 2 different tribes in the camp, and there was a lot of hate speech between those tribes, and they didn't know what's happening in the camp, so they packed up their supplies, they went to do a displacement camp clinic, and when they landed, the tribes were like, okay, which side are you going to do this clinic on? And they're like, well, we're just here to do a clinic. We don't know which side. And I'm talking about students, youth, residents going there not knowing what's happening. They're like, oh, no, you have to decide which tribe you're serving today. You can't do both tribes at the same time. We're not going to work together on this. And they basically said, okay, well, we can do the clinic for both tribes, or we can pack up and leave. So you guys as tribal leaders need to decide how this day is going to go. And they sat down with them. They had a dialogue about, let's see how we can creatively make this work. And they ended up holding the clinic in the middle of the camp and having 2 doors to the clinic. One person from this tribe enters and one person from the other tribes enter, and they basically rotated the clinic between the two tribes. And it was somewhat hectic and dysfunctional to do it that way, but they said by the time they finished the clinic, the two tribal leaders came at the same time and shook their hands, and they thanked them for what they did. And that moment of seeing them together, thanking them and smiling at each other was just a great gratifying moment for them. So I think by being that person with privilege and trust, you can use that in a way to actually mobilize a little bit better towards peace. So thank you.
Any questions online?
There is one, a little, I guess, if you want to add anything. You've definitely covered some of it, but what was your strategy for working with the Ministry of Health and navigating typical red tape to get work done, and what advice do you have for someone wanting to have those conversations with their Minister of Health?
Yeah, that's a really good question, and I don't really have an answer to say that we did that effectively. What happened is that it depends on who actually is there in that position. That makes a big difference. I was so lucky that the person who was in the position that we needed was actually a classmate. So I was like, okay, it's a friend, I have their phone, let me pick up the phone and talk to them, and that made a difference. I mean, it wasn't like, oh yeah, great, thank you for doing this. No, it was like, well, we have a process, you have to go through the process. But if that message came from the minister, it makes a big difference than me going upward and doing that. So it's somewhat, probably not the right way to do it, but if you're doing it for the right cause, honestly, I feel like you have to leverage those resources and privileges. But in other places, we had a lot of opposition, and we were shut down by the Ministry of Health, the state Ministry of Health. So it's not always a success, but what we found is building relationship over time. So the Ministry of Health, for example, in Northern State, is willing to engage us in any effort that they have, because we were there when they needed help with vaccination. We gave them volunteers who did this work for them and helped them get vaccination across the state. So they have that respect and relationship with them. So if they need to navigate that, it's much easier for them. In other places, we don't have relationship. Yes, Dr. Delaire.
Excellent talk, Lois. My question is in interprofessional education. You talked a lot about residents and I assume medical students and trainees across the learning and professional spectrum. In many of these hard-to-reach areas, the students and their professors were all going out there. But as part of building a long-term capacity and dealing as well with the brain drain, how do you see, for example, nurses, allied health professionals, any engagement in all of these other sectors to make sure that all of the efforts remain?
Yeah, that's a wonderful question. So what we found eventually is that depended quite a bit on the program. Some programs, when we tried to engage everyone in the same program, some of them benefited more than the others. So it was kind of it promoted disparity in learning, unfortunately, because we were delivering the message with medical students and medical professionals in mind, but we had nurses, we had laboratory students, we had public health students online with us, and they were disengaged. They just didn't feel like this is the right thing for them. So I think if you do it that way, you have to really think in an interprofessional mindset. So what is the activity that we're going to do that will engage everyone and they feel like they have a role? If I do an activity during this session, I need to include nursing as active participant. I need to think about public health staff as active participant. So it really depends on the topic and the activity that you're working on at that point. Vaccination was a great example. So in these vaccine convoys, there was participants from all across disciplines. There were medical students, there were nursing students, there were pharmacy students, et cetera, and everyone felt that they have a role and they have something to participate. Pharmacy students knew exactly what the temperature for vaccination needs to be, how to actually get those checked, et cetera, et cetera. Nurses, had really good skills when it comes to administration of vaccinations, so everyone was feeling like, okay, I can do something and I can own something here. But in some of the activities, it was like some of them had to step back and feel like this is not for me. So we had to kind of think a little bit about that, and I'm not sure if it's suitable for all activities. We haven't really yet figured out a recipe, honestly, that will say, this is what's going to be interprofessional, this is what's going to be targeting medical students. So we're still in that mode of like, everyone is involved, but it may be for you, it might not be for you that day.
Otherwise, just lots of "you're awesome" comments and thank you comments. Best ones
Thank you.
they've heard in 20 years, so I'll share all of those with you. Because there's some big hugs in there for sure. And even some of your mentees chimed in and said thank you and enjoyed their time with you. So I appreciated our time today too.
Well, thank you. Appreciate you, and I hope to see some of you hopefully engaged in this type of work in the future. So thank you so much.
I'd like to